Good morning and สวัสดีค่ะ I'm from Thailand. I'm a pediatrician. สวัสดีค่ะ So my session today, I would like to talk about women and children. And I'm very glad that this morning, Dr. Nitya talking about integrated 95, and she also mentioned about 90% of women can get access to HIV care, and also 95% elimination of vertical transmission. So I would like to continue on that topics about pediatrics and children. So may I ask people in this room, how many of you have seen children exposed to HIV, adolescent living with HIV? Oh, so more adolescent or children. Do you see under 5 living with HIV? Yes, yeah. And why do you see under 5? Because they are develop AIDS symptoms, or because they know that mother have living with HIV and they was diagnosed in the first day of life? Yeah, so it's mean like children can get access when they develop AIDS. But nowadays we are living in a world of HIV. So in Thailand we screen all pregnant women, and then we expecting and then try to diagnose them since the birth and diagnose within 4 months of life. So I will explain more on that. The reason that I keep talking because it's not advancing. Anyone help me? Please, thank you. ล่างแล้ว Thank you. Okay, so this is the picture of the situation of pediatric HIV around the world. So 1.5 million children living with HIV, and Asia Pacific is the second after Africa. So about 130,000 children living with HIV in Asian Pacific. And luckily we have a chance to protect or converted children living with HIV in the past 20 years. Globally, 3.5 million children has been saved from acquiring HIV. However, most of that occur in Africa, not in Asia Pacific, because the belief that Asia Pacific has low prevalence, that is the first barrier. How low that you tolerate. I think if we're talking about that prevalence less than 0.1% is low, then we don't do anything about children in this country or in this region. But when I talked to my colleagues, she said that one child infected with HIV is high enough to be a threshold for you to take action. Next slide, please. So this is the overall slide that 1.2 million newborns are exposed to HIV each year. However, who are infected, who are acquired HIV, the orange one, about half of children acquiring HIV because mom doesn't know her status. Mom doesn't know her status, so she cannot have a chance to protect her baby. So what is the most important if you want to do prevention for baby children? I think the most important is to have her mom get tested, to have women be able to get tested. Next slide, please. So this is a recommendation that we should test all pregnant women in antenatal care. I think the difference is that when you try to work with the population, you need to have a strategy to recruit, to have demand creation. But for women, all women, young women will come in the antenatal care for deliver baby. That's the chance that you can implement testing. And also hepatitis B and syphilis has been treated, but we didn't implement HIV testing at a high coverage. So the WHO also mentioned that dual HIV and syphilis testing, one rapid diagnostic test, one single blood drop can test both disease and can be benefit for both mother and baby dyad, and also to their family members, because we know that if mom educated, mom know about this, she can not only do it for herself, but maybe other siblings or maybe other relatives. So can we implement HIV syphilis RDT in antenatal care? However, it was recommended as universal testing opt-out, meaning that we didn't mandatory her to get tested, but we offer the best package for women. And when I listen to Dr. Nitya talk, what is your pleasure of having sex? And I would say that the pleasure of having sex for women is having healthy baby, right? So that is the motivation. Motivation is already there, but how we can frame this as a positive way to help her to have a normal, healthy baby. And overall coverage in Philippines, I think the coverage of syphilis testing in antenatal care is 26%. So if we do the same way, it will be increased over time. But I encourage you to think about it in an opposite way of universal opt-out, meaning that we will do it, offer it as a package to every woman come into service, unless you say no. I would say that, Mom, we would like to help you to have healthy baby. Syphilis and HIV is the infection that baby can acquire. We will offer this test unless you say no. You think that mom will say no when you say something that is benefit for baby? So it's just in hand of our policy and also our implementation that would we want to offer this to pregnant women. And another, sorry, can we go back? And another important one is for baby, for children, HIV antibody cannot use for baby age less than 18 months old because antibody is from mom to baby. So in Thailand, we do HIV DNA PCR, which can be done logistically that we can use blood that from baby little foot and then using 5 blood dots and then send it in the room temperature because the DNA is very stable, send it to the central lab and then we get diagnosis for infant. And if they have infection, we can treat. Next. So how about treatment? I think in pediatrics, we also use the same as in adult, DTG based. Dolutegravir is the recommended. And from the Odyssey study is showing that both first line or second line, dolutegravir can be one of the best drugs. However, what you use in adult, TLD, right? Tenofovir, lamivudine, dolutegravir. However, tenofovir has effect on bone. So the recommended regimen for baby is ALD, abacavir, lamivudine, and dolutegravir. However, in pediatrics, we also have a little bit more complicated on the size of the baby. Baby can use TLD, or children or adolescents can use TLD when they are over 30 kilograms. If they are younger than that, we need a pediatrics formulation. Next slide, please. Yeah, this is to see how they are simple chart of how to use it. So if they are 30 kilograms, they can use the same as adult regimen. But if they are younger, we will have, it's called weight-based regimen. You can calculate weight and then use the proper regimen for young children. Next, please. Okay, and how about 90% of vertical transmission elimination? So this is the study showing that, do you remember that before this we used efavirenz and then we changed to dolutegravir? When we have a dolutegravir transition, we have a bit concern whether dolutegravir has effect on neurotube defect or effect on baby anomalies. But when it's used and collect more data, that concern is lifted, no problem. And also this study comparing between dolutegravir, TAF FTC dolutegravir, TDF FTC dolutegravir, and then TDF FTC and efavirenz. I would like to get attention on the last one. HIV infection in infant or infant acquired infection is about 0.5% or 1%. But if they not get medicine, it would be 30%. So efficacy for baby is okay. And another one is infant death and infant preterm. This study showing that dolutegravir has only 1 to 2% infant death comparing to efavirenz. So this slide is reassuring that if women get tested and is positive, TLD that was used for adults can be used in pregnant women. Next slide, please. Yeah, I think, and the last one is for older children. I think another message and another differentiated service that we should talk about is how we can provide care for adolescents. I think the most important one for adolescents is that the service should be safe space for them. We care about them access to us. We care about retention to service. However, we know that it's during developmental milestone. So sometimes they not get viral suppression the same way that we expected in adult. But when you're working with them, eventually they will reach viral suppression and can achieve zero transmission. Next slide, please. I think this is the last slide. So I think the bottom line is that women and children should have a chance to get tested. And then after tested, they can get into the cascade of care or prevention the same way as other population. Thank you.